But so I'm Jen Bedford. I'm from the MND Association in the UK. I'm Head of Partnerships, Education and Information. And I'm going to talk to you today about the NICE guideline for MND and the review that we've done of it recently. Well, over the last year, really, I would have to say. And how do I move things on? Okay. Right, so just to start really with a summary. So the NICE guidelines are produced by the National Institute for Health and Care Excellence, and they're evidence-based recommendations for health and care in England. They're also applicable in Wales and Northern Ireland. And they set out the care and services that a person living with MND should expect from their care. And the aim is to help prevent ill health, at the risk of reading directly from the slide, promote and protect good health, improve quality of care and services, and adapt and provide health and social care services. So it should lay all that out, and part of our literature that we have is a guideline for people living with MND about this and what to expect from their care, and we have a short piece of information about that, so it's very important to us from a patient perspective, but also for professionals that are providing the care for people living with MND. So they're quite key things for us. So the reason it came under our scrutiny was it was first published in 2016, and NICE guidelines should be reviewed every 5 years. That's the cycle of it. And we got to 2021 and there was no sign of it being reviewed, so we felt that we would have a look at it ourselves. The issue that we've got is that MND is quite a rare disease, and also there are quite, for that reason, there are a small number of people with it. And we're very lucky to have the guideline for this condition. So it was updated last July 2019, and not a great deal was updated on it. So in terms of the research that goes on, I think we've heard that from many of the presentations already. We have small studies, small study numbers, and we can't do the kind of research that NICE is kind of looking for really in terms of randomised control trials, etc. So NICE set quite a high standard for their evidence that they can put into the guidelines. So in terms of getting a NICE guideline updated, or for it to come to NICE's attention, they carry out what's called surveillance, and they aim to check the guidelines are up to date, but there are many, many hundreds of guidelines. So we feel it's important for us to keep an eye now on and make sure that we're there representing the people living with MND to the people at NICE to say, hey, things are changing out there, and we need to do the best we can to make sure that guideline is updated and that professionals have the latest information about how to best care for people living with MND. What would trigger a review for NICE is to new evidence which contradicts what's already going on in the guideline, a new intervention that might come out, and contextual changes such as policy. So an event would be a direct publication of a study that's bringing out completely different information that's in there. And what happens if there is an event is that triggers a topic expert panel to come together. They would do a literature research and they would look at all the intelligence that's out there. So a big process starts at the point where it's identified that there may be something that needs to change within the guideline. And clearly that wasn't happening. So what did we do? We convened our own expert review group made up of a significant number of eminent professionals in their field. So we decided to go right to the horse's mouth, talk to people about what was going on and what had changed. We did a literature review of our own and had a look at what was going on out there, and we considered all of the areas of the NICE guideline. To start off with, we looked at the things that NICE were most interested in. So back in 2016, when they wrote the guidelines, there were some areas they were particularly interested in, and they said they had their eyes on, if you like, around it. So we particularly investigated those ones because we thought they're already interested in that, so maybe they'll listen to us if we can find some changes. So there's organisation of care. They were interested in the network-based model versus the clinic-based model. They were interested in cognitive assessments, impacts of cognitive assessments, how often they should be repeated, etc. There was a prognostic tool at the time. They were interested in that and how that was going on. Saliva, how are we managing saliva? Interesting, AAC. We've had a lot of talk about AAC today. They wanted to know what the pattern of provision was like for AAC. Nutrition, this high-calorie diet affects survival. Exercise prescription, that's a perennial one. I'll come back to that one. later, and also peak flow cough augmentation. So they were the ones that NICE were particularly interested in, so we had a focus on those to see what we could find. What we found was not a great deal more evidence, to be perfectly honest. Unfortunately, what we couldn't do was pull together something that was an absolutely compelling argument that we could put to NICE. However, that said, when they first wrote the guideline, one of the considerable things that they did was rely on professional consensus opinion. So using the evidence that is out there, using the professional consensus opinion of the expert topic review group that they had in the first place, the guideline development group, that's how the consensus came. Look at the evidence that's available and take the professional consensus view. So we decided to present our evidence in the same way and to be able to say to them, actually, have a look at this and see what you can consider. So the areas of interest that we came out with after we did our review, we felt that information and supported diagnosis, we felt that had probably moved on, and the reason we felt that had moved on was because of genetics and the genetics question that we now have. There's a lot more information we have around the prevalence of genetic causes and also how to interact with that once that's happened. So what we'd like to see, we're still in the process of interacting with NICE, I should make that clear, we haven't stopped. We wanted genetics listed in what a neurologist is able to talk about to somebody when they come in first with their diagnosis of MND. It's clearly something that's important to people living with MND and their families. So that's what we asked for. We also think that there should be the process for counselling and testing laid out in there as well, so people really know what they can expect when they go for that dreadful first interaction with a neurologist in many ways. Cognitive assessment, what we want, there are now validated tools for cognitive assessment. We feel those should be listed in the guideline. The prognostic indicator that they had at the time fell by the wayside, but we do now know that potentially cognitive and behavioural change can be a prognostic indicator, and we feel that should probably be listed as well. We'd like, in the organisation of care section in the NICE guideline, to have a psychologist listed in the MDT that's supporting somebody living with MND. There's lots of studies that are ongoing, I have to say, that are showing and demonstrating. I mean, it's fairly obvious it would support somebody if they had a diagnosis such as MND, that psychological input would appear to be, I would say, a logical thing that you would expect to be there. We also feel that people may be aware of it in the room, the COMMEND study that's gone on, for example, around psychological support. We felt that there are some specific interventions that could now be listed in the guideline. Communication, when we looked at communication, we found there's a real paucity of evidence supporting communication and why it should be there. It's obvious. We know why communication should be made more available to people living with MND and the interventions that should be there. But actually, there isn't much evidence to support us being able to make that case. What we did ask for was for them to consider that early intervention, getting someone to bank their voice or message bank early on in the process seems to be a logical thing that we should be able to ask. It's done for something like PEG. Why can't it be done for communication when communication is so pivotal to people getting the right therapies in place? So that's what we want to get to that point with. Cough augmentation. We felt that there should be some acknowledgement of the impact of cognitive and behavioural change on the ability to take part in cough augmentation, and also the care burden for somebody supporting someone having cough augmentation. So we found things that we wanted to know, really, is what we came out with. So what response could we make to this? So we sent in a report to NICE, and we've registered all these things that we're really keen to see change. And we're waiting for, as I say, we're on that ongoing that process, interacting with NICE. But what do we do now? So I think this is the thing going forward. We can take two responses, we think. We want to create more events, and by that we mean let's have a look at the research that's going on out there. Let's make sure the research actually meets NICE criteria, or we can bring it all together, and I'll talk a bit more about that in a second. And we also think there's a place for practical pathways, and we've heard a lot of those today in the room around how the actual care is being delivered out there. There are lots of good practice. Let's share good practice. We also set out some research priorities that we wanted to cover. So we looked at the whole guideline, and we've identified, this is with the, I should say again, with the topic expert that we worked with, we identified sort of research questions for all of the NICE guideline areas, actually, but then we undertook a process of what are the research priorities? What do we really want to see in these areas? And I will... It's not just us in glorious isolation, I have to say. So this is a starting point. So we felt that and the numbers by the side of it are the recommendations in the NICE guideline, if anyone's wondering why I put 1.8 followed by 1.3. So 1.8, pain, secretion management and exercise. We feel that really does need looking at, and we wanted to come at that from two different ways. So the exercise in the guideline currently says you give an exercise program that's suitable for someone living with MND. We've never really got to the bottom of what that means. We don't really know what effective means. We're not going to make sprinters out of people living with MND, but people need to exercise for mental health as well as anything else. So there's a whole thing to unpick there around that. In terms of cognitive change, we now want to say that one of the questions we set there is how are assessments best used in practice? How often should you repeat them? We know we've got them now. How do we use them? How do we go ahead and use those? Communication, one of the questions that we set there was the importance of communication for acceptance of other therapies. How does it affect the acceptance of other therapies? And also things like which bit of AAC works and why? What's the thinking behind it? 1.4 was investigation of new prognostic tools, potential for validation. 1.6 is the psychological side of things. I think I've skipped my slide too far. I'll go back. So are the benefits of a psychology post into an MDT? We haven't got the evidence of that yet. That's what we need to get to. That's what we want to do. What are the effective psychological interventions for carers is another question we thought would be a good question to have answered. 1.13, so cough assistant, is peak cough flow a useful indicator to inform the initiation of choice of cough augmentation technique? And also on that one, early intervention with cough augmentation, does that make a difference? So we've got lots of things that we're wanting to investigate. And now I'm going to talk about how we think we might go around that. So we want to steer a proactive research programme that feeds into practice, education, information, which is my area, so the information side of things. And we want to set up research to care groups. So we're running 2 pilots for the research to care groups at the moment, possibly a third one coming along. And what we want to do here is get together the people that are working in these areas, see what's happening, because we know that we don't know everything. But we want to get the people that are working in these areas to talk and collaborate and see what's actually going on. So those questions that we've answered and that we've set ourselves may well be being answered somewhere. And we just want to bring things together. So it's a kind of a jigsaw approach. So if you're doing this and you're doing that, let's get those things together and then we build the evidence base better for NICE. So we start to create these kind of symbiosis really of research that's going on out there, getting people to talk together. The 2 that we've set up, so we've set up one in communication and we've set up one around exercise as well. So those are the 2 that we thought, and possibly the third one will be around psychology. The second thing we want to do is look at real-world evidence and real-world data, and that's something that NICE are particularly interested in, and this is an area where we might have some strength because we know that these things work, and if we can use different types of data to show the effectivity of the things that we want in there, we'll be able to use real-world data and evidence to prove it rather than having to wait for clinical trials that sometimes we can't get to the right level that they're looking for at NICE. This is our opportunity really to show real-world stuff that works in there. And the other thing in that space to say is they're also looking at how to use patient experience data, and I think that's really quite exciting in itself. What we need to do with this, though, is present it in the correct way, in a way that they'll accept. So we need to understand what those parameters are that they're looking for so that we can say, well, actually, here it is. Here is the data in a format that you're prepared to accept. And we've also got professional consensus opinion behind it as well. So we're starting to build our cases. We want to develop a community of AHP researchers. So if anyone wants to talk to me about being involved in anything, be delighted. I think if the more multi-centre studies that we do, again, the more we're coalescing things. We all want the same things. This is what I keep hearing in the room when I'm listening to these presentations. We all want the same thing. And if we can work together, I think that's going to be really, really powerful. Other things we're thinking about are practical stuff. So a platform on the MND Association website, patient decision aids are being made. Let's get those all together. Let's get those in one place so people can find what they need more easily. Sorry, I'm so short, I have to look around the side. So we've got a community of practice at the MND Association, which brings together allied health professionals to talk and discuss about what their practice is. What we want to do is look at the profession specific in there and talk to them. So, okay, let's talk to speech and language therapists and get those together, find out what's going on in the workforce and talk to them and really start to create those as well. And products and tools, so we want to be able to produce practical things. So whilst the NICE guidelines are great to have, we also know practice goes on anyway, so we want to really try and make sure things are happening properly. And one of those things, for example, that we're looking at is a pain pathway, so a pain management pathway, and looking at those. We also want to make sure that we're spreading that information out as well, and that's what the community of practice is about promulgating the stuff that we're producing, not in splendid isolation. And we also want to make sure, obviously, the patient voice is heard, and that comes back to that point of the patient experience data that we'll be able to use with NICE. So thank you very much for listening.
Thank you very much, Jennifer.
You're welcome.
Are there any questions? There is a question just there.
Thank you. That was really interesting. Jo Whitehouse from MND Victoria.
Hi.
In Australia. I'm just curious what advice you would give to countries that don't have best practice clinical care guidelines. And it's something that we're toying with at the moment. And, do you start from scratch in relation to your particular scenario in your country or area, or is it something that you could crib and tweak?
Well, my personal view would be to start with a NICE guideline. There's no harm in starting where it is. It's not a bad thing. It lays out everything from information at diagnosis right the way through to NIV care, which is there, so it does cover the things that have been talked about earlier as well. And it's there, and I think that the bones really are there. I think our job as a collaborative is to make sure that we can, for me, it's the implementation of those guidelines. And I think there's potentially a way of almost working backwards if you've got a blank slate and say, these pathways work, and then sort of going backwards. And in that way, you've got the practical stuff, you've got the evidence, we've got the evidence, we can work together to make more evidence. But everywhere's going to be different. So what works in the UK won't necessarily translate. So those practical things, I think, would inform your particular area. But I think the guidelines are they're sort of common sense, ironically, in a way. It's just getting NICE to accept common sense, just demonstrated by evidence, I think. So,
hello. I'm Dr. Rick Nelms.
Oh, hi.
And I'm a biologist from Cambridge and an artist. But the main reason for asking a question is that we have had a lot of experience with the hospice movement, and particularly with the living well care over a period of time. And it seems to me that there's an opportunity to build stronger connections between what you're trying to do and the evidence which can be collected through hospices.
Oh, I agree. I think we do work in partnership with a number of hospices. We've got some flagship hospices, particularly. I'm thinking of Loros, particularly there, where they're virtually an MND centre in all of themselves. And I think, Rick, this is where we're moving. That's the patient data, isn't it, for palliative care?
Yeah,
that's where we can look at what the patient journey has been, and I think that's where the strength lies. Absolutely agree.
Okay, thank you.
May I just check if there's any questions online? No? I think anybody else in the room? No? Well, thank you very much. Thanks, Jennifer.
Thank you.